Guess what? Of course they get gestational diabetes. They have increased fuels, and what do they pass over to their child? And so we get this renewing circle of passing obesity and diabetes from generation to generation. Wouldn't it be great if we could break up that cycle? Is it possible that treatment of gestational diabetes can reduce downstream fetal obesity and downstream diabetes? Well, let's see what we got. So first of all, here these are called randomized controlled trials. The first one was done in Australia and New Zealand by Carolyn Crowther, and they simply asked the question, is gestational diabetes a real thing? What happens if we just don't treat it? And so what they did was they had the routine care group, 510 of them, and they had the intervention group who got regular old diabetes care during pregnancy. They were diagnosed with a 75-gram glucola test, fine. And so we had one group that was just get routine care, and it was all blinded. What happened? Well, they got the babies in the intervention group were smaller. Only about 100 grams. I don't know. That doesn't sound like it's going to make a big difference. But wait a minute. Look at the babies that were large for gestational age. That means they weighed more than the 90th percentile for their gestational age. Cut almost in half. How about macrosomia? More than 4,000 gram babies. Cut in half. Maternal preeclampsia, by the way, reduced as well. But this suggested that treatment versus non-treatment of women with gestational diabetes made a big difference in the adiposity of their offspring. Next one. Mark Landon said, okay, you proved that gestational diabetes is a real thing, but let's take the Maternal Fetal Medicine Network, 14 places selected around the United States to do this trial, and we'll take all these women with gestational diabetes, but the women who have normal fastings. They have a mild form of gestational diabetes, and let's treat them and see what happens. And sure enough, the untreated group, you see in this column, versus the treated group, it's only 100 grams, big deal. But look at if you take birth rate more than 4,000 grams, those are 9-pound babies, cut by 2/3. More than the 90th percentile at birth for gestational age, cut in half. Neonatal fat mass, significantly reduced. And by the way, dietary treatment alone was what was used for over 90% of these people. And this is not a lot of drugs. This was dietary intervention that made such a huge difference in the adiposity of these children. So, if gestational diabetes treatment is beneficial, then who should be treated? Well, you would think people should be treated if they're at risk for having a fat baby. So let's just go over our existing criteria for diagnosing gestational diabetes. First, O'Sullivan and Mahan, who were at the Joslin Clinic at Harvard in Boston, were taking care of women with diabetes and women who didn't have diabetes, and they were interested in the people who, after a pregnancy, developed diabetes. And so they developed our favorite 100-gram, 3-hour glucose tolerance test, and they defined the cutoff values for this to be predictive of someone developing adult onset diabetes within 5 years. So they looked at their population. They said, sure enough, if you have 2 values over one of these cutoffs in here, you're very likely to develop diabetes in the next 5 years. It wasn't about the fetus. It was about the mother. Now, there have been a bunch of changes that basically had to do with the instrumentation. You know, it wasn't whole blood anymore. We were doing plasma, and then we were doing capillary glucose. And so you can see here's Carpenter and Kustin, and then by ADA, and these are sort of the values we used today to do the 2-step testing. So you have an abnormal first step with 50 grams, and now you do 100 gram, 3-hour test, 2 abnormal values, makes you gestational diabetic. Why? Because we want to find the women who are going to be developing diabetes in 5 years. Is that right? Is that what we want? Or do we want to help a baby from getting fat? That's the conundrum. And that's where we've been hanging out here for about the last decade, a little frustrated with we might not be doing what we thought we wanted to do, because we might be prolonging the onset of overt diabetes in women 5 years after a pregnancy. We might, but there's more to the game than that. So, by the way, I just wish everybody to know that in the United States, the O'Sullivan and Mahan system, it's the only place where the 3-hour 100-gram glucose test is used. In the rest of the world, you see World Health Organization recommendations down here. Really, it's a one-step process, so none of this 50 grams and followed by 100 grams. It's a simple, one-time 75-gram glucose test given at the start of the 3rd trimester, and you've got to have an abnormal fasting, and usually an abnormal fasting is typically used as 95, and an abnormal 2-hour is usually somewhere in the 160. It depends on the particular group and what part of the world you're in. But the point is, we're the only ones who have the 2-step test. What about this 2-step test? What's wrong with it? Well, first of all, you remember, you have to get in the club, you have to have an abnormal 50-gram cutoff. The cutoff for that, according to the ADA, is either 140, 135, or 130. It actually says that. So how do you decide? Well, first of all, you can see here that if you use a cutoff of 140 for your 50-gram cutoff, you will diagnose 80% of the people who actually have gestational diabetes, meaning 20% will slip through, meaning 20% will have fat babies. And 20% of those fat babies, many of them will go on to have adverse childhood and adult metabolic lives. You say, well, okay, let's go down to 130 then. Okay, sure. That only picks up 90% of the individuals and leaves a bunch of babies getting by. And it was this feeling that there are and everybody who's practiced obstetrics or cared for pregnant women has noticed that we have people who have negative glucose tests who show up with fat babies. And in fact, I saw one just the day before yesterday. The baby was huge. There was hydramnios, and her test at 25 weeks, 1-hour test, was 145. And they were using the 150 range. And she hadn't been tested. Now, here's sort of the proof in the pudding. This is California Sweet Success data. Here is the likelihood of being obese, which is the red bars are babies between 9 and 10 pounds, and the yellow bars are, God help us, the 11-pounders, actually over 10 pounds. So you combine those two together. If you have type 2 diabetes, overt diabetes, 16% of those babies are obese, as the definition. If you have type 1, 20% of those babies are obese. If you have gestational diabetes, only 11% are obese. Sure, it's an earlier phase and whatever. What is this thing over here called impaired glucose tolerance? Those are people who took the 3-hour test, had one abnormal test. They had one abnormal test, and their doctor or their nurse or their clinic manager said, you don't have gestational diabetes, go away, you're fine. Or hand them a little dietary sheet to follow, and we'll see you later. And look at what happened. Right here in the state of California, 15% of the impaired glucose tolerance who had only one abnormal value on the 3-hour test have fatter babies than the people who got care during pregnancy with diet, exercise, and occasionally medication. I think this is an indictment of the system we've been using, and we've got to do better if we care about the health of our population. So, and it's a little bit of a problem, because here, what I've got plotted for you, if you look across the bottom here, this is the 3rd trimester of pregnancy. Starting actually, 3rd trimester starts right about here at 27 weeks, and you'll see that growth by the baby, fatness, peaks at about 33 weeks. And then the putting on of fat on a baby drops way down. In fact, it goes negative after about 42 weeks. So if we're going to make a difference in baby fatness, we got to get after it maybe before here. We got to get going. Let's see how this works in the 2-step testing. First, our doctor orders the 1-hour glucose tolerance test, and orders that about 26, 27 weeks. Of course, it takes a little while for the patient to do the test, and then the staff to call her back and say, by the way, you need the 3-hour test, and we order the 3-hour test, and finally the patient does the 3-hour test, and it's abnormal, and then we attend the class. You notice our baby is already halfway through the fat, and then by the time we start the medication, we've already become fat, and before you know it, we look like this because we're using a 2-step test. So can we do better? That's the question. So we end up with this brilliant study done in 25,000 women at 15 centers in 9 countries. I mean, gosh, what a job to put all this together. But to answer the question, one and for all, globally, how is it possible to have a fat baby? Or who are the people that have fat babies? So let's see. They used the 75-gram glucose tolerance test because that's what you use every place in the world. They applied it at 24 weeks, basically 24 to 28. But they allowed people to be diagnosed as late as 32 weeks. Remember, 33.5 is where the peak of fatness occurs. So they were diagnosing these people prior to, by 32 weeks. And then they ignored all the ones with gestational diabetes. And we only focus on the ones who didn't have gestational diabetes. So let's see what happened. They looked at, for outcomes, they looked at babies that were over the 90th percentile for weight and gestational age, and that's corrected for ethnicity and country of birth. They looked at the incidence of low blood sugars after birth. They measured the insulin levels, the C-peptide levels in the umbilical cord at birth. They monitored the cesarean rate, and then looked at babies at some of these important things like how fat were you? Did your shoulders get stuck during birth, and so forth. All right, let's see how this turns out. Now, there's a lot of stuff, but just look at this one. I think this is very interesting. This is the frequency, the percentage of babies born more than the 90th percentile for gestational age. You can wrap your head around that. So you'd figure that up to about 10% of babies should be born at the 90% or greater. So that's all these kids right here. That's 10% born greater than 90th percentile. Well, that's about the right number. And so you've got 3 curves here for birth weight above the 90th percentile, percent body fat above the 90th percentile, and percent insulin level in the baby's cord blood over the 90th percentile. And you can see for any blood sugar less than 90, you have about the right number of babies that you should have, somewhere around 10%. But look at here. If we say, oh, it's okay to have a 95 when you're fasting, look at the likelihood that you're going to have a fat baby. Instead of a 10% chance, you're almost 20% chance. And if you allow a 100 and say, okay, your 100 on fasting is okay, maybe 105, we're going to use 105. You're going to have up to twice or 3 times as many babies being fat, having too much insulin in their bloodstream, and being overweight than you should. So this is how, by selecting these cutoffs, we predestine ourselves to decide which kids we're going to care for during pregnancy, because we can care for a fetus in pregnancy. We're choosing which ones we can and cannot care for depending on how we choose our cutoffs. And these are all kids who were told, their mothers were told, you don't have gestational diabetes. You're fine. See you later. So HAPA went back over these data. They considered the following. If we want to do better about and hold the number of babies born above the 90th percentile for weight, fat, and C-peptide insulin to 10% or less, right? That figures. Then we need some values on the 75-gram test that will do that. So what they decided was, well, we can't take every single baby who's going to be slightly over the limit. So they said if the likelihood that the baby is going to be born fat or overweight is almost double, or 1.75 times average, so the cutoff was 1.75 times average. So if your risk is almost doubled, then we put you in we're suggesting you need to be treated because we know we can treat you. So let's say if you're almost doubling your risk of these bad things, let's put you in the group. What values on the 2-hour glucose tolerance test do we need? Remember, in the old days it was 95. Some places, World Health Organization uses 100. Nope, 92. You saw that curve. Similar curves showed that a 1-hour value at or above 180, no good. At or above 153 at 2 hours. These values put you in a high risk for fatness group. And so the data show that any one of these values is enough to put you in the fat group. Okay, so now we have the basis on data collected worldwide of telling us what values your mother would have on a 75-gram glucose test would put you in a risk of almost doubling your risk of being fat at birth.